Good morning. Welcome to today's edition of Urology 60 Minutes from the University of Southern California, USC Department of Urology. We have been doing this weekly Thursday morning 1-hour session and have had some very encouraging feedback from the various attendees. Our session this morning is regarding male infertility, and we have an absolute all-star cast of faculty and visiting professor speakers. Dr. Robert Oates is professor of urology at the Boston University School of Medicine. He is also the program director and the fellowship director at Boston University. Dr. Oates needs no introduction. He has been heading up various formal organizations in male reproduction, board of directors of the American Society of Reproductive Medicine, board of directors of the WHO guidelines, president of the Society of Male Reproduction and Urology. And in addition, he has been, really brought this specialty up to its current status along with his colleagues. Did the first papers and work on intentional cryopreservation of sperm, which is now obviously common at many centers. Thank you so much, Dr. Oates, for joining. Also with us is Dr. Jarvi. He is from the University of Toronto from Canada. He is director of the Wellness Center at the Mount Sinai Hospital and head of the Division of Urology at Mount Sinai. He is extremely well known in the field. He's funded by the Canadian Cancer Society, the Mars Innovation, and Canadian Institutes of Health Research. He's on the board of directors and was president of the Society for Male Reproduction, is on the scientific program committee. And for us at USC, a real personal connection with Dr. Jarvi. He was the director of the fellowship where my colleague, Dr. Mary Samplaski, did her male reproductive fellowship at Toronto. And finally, we have Dr. Hotaling. He is from the University of Utah. He's director of male infertility at that institution and is a fellow of the European College of Sexual Medicine. He is also fellowship trained in both in male infertility as also in reconstructive surgery. Multiple publications, over 100, funded by the NIH, and is editor of one of the editors of Fertility and Sterility, one of the premier journals in the field. It is a real pleasure to welcome all three of you today. The USC host is Dr. Mary Samplaski, my colleague. She did her fellowship at the University of Toronto with Dr. Jarvi and is now one of the premier experts in male infertility on the West Coast. She is really one of the leaders in the department. And without further ado, I will pass it on to Dr. Samplaski. Mary?
So I just want to, again, extend the warmest welcome to all of our speakers and a huge thank you. During these times, one of the silver linings is that learning is still happening and the opportunity to sort of reach colleagues that otherwise might be a little far away. So I know internally we are very excited for the lectures to come, and I know there's been a lot of external excitement, so thank you to the speakers. All three of these speakers are amazing physicians, outstanding scientists, and wonderful humans. I've had the opportunity to see Dr. Oates speak multiple times at AUA and ASRM. He's up in Boston, and we've actually shared lobster rolls up there a couple of years ago. He is one of the most spirited speakers that I've ever seen, and some of the debates that I've seen him engaged in have been some of my most favorite lectures from over the past years of my training and being in practice. So we're very lucky to have you come speak. Dr. Oates, take it away.
Okay, Mary, thank you very much. Dr. Gill, thank you. And Mary, thank you. So are you seeing my screen? Here we go. Let's go on to PowerPoint. Share that. Okay, so are you all seeing my PowerPoint presentation? Thumbs up. Okay, here we go. So what we're going to talk about today for the first 15 minutes or so is just syndromes of basal agenesis. And I think, you know, one of the things that's important about this is that I'm going to try to encapsulate not only a little bit of the clinical, but also the genetics, as you'll see. So here's some learning objectives. We won't take the time to go through those. I have no disclosures. And so the outline is going to be, one, I'm going to start with the importance of the semen analysis details. I think they're critically necessary to understand when you start thinking about an azoospermic sample. We're going to talk a little bit about the embryology of the mesonephric duct, and I'm out in Boston, but I can hear this collective groan coming through the ears from all the residents. It's not going to be that detailed, but just enough, so bear with me. And then we'll get into CBAVD and some of the genetic etiologies. One of the things I always preface my talks with, especially for the residents, is don't go into something and just perform what I call shotgun diagnostics, where, well, I know he has no sperm, so I'm going to order all the tests that I've ever heard in any of the talks that I've ever listened to. Try to be a little bit more tailored, a little bit more targeted. It makes medicine a lot more fun when you're thinking about disorders and diagnoses and then doing your testing based on what you're thinking about. A lot more fun and enjoyable. We order these tests in an infertility circumstance, not only for the male himself to figure out why he has whatever problem he has, but in infertility, we're also dealing with the couple. So we always have to think about that. So it's not just one person, it's two. Actually, it's not just two, it's more than that because we have to think about the child as well. So the offspring, when we're talking genetics, is just as important to us as the patient and as the couple is. And you'll see how that plays out in some of the genetic etiologies that we discussed. So in the differential diagnosis of azoospermia, when you hear a patient has an azoospermic sample, ask about the volume, ask about the pH. They can be critically important in helping you figure out what is the differential, as I'll show you in a second. We can break down azoospermic patients in a low volume or normal volume. And now, if we look at behind the bladder, so here's the end of the vas, the basal ampulla. Here's the seminal vesicle, which comes off the lateral side of the vas. The seminal vesicles, we'll see, makes most of the fluid in the ejaculate. The vas and the seminal vesicle, you can see here, join actually outside the prostate to make the ejaculatory duct. The ejaculatory duct is paired. That's what delivers fluid from the vas and the seminal vesicle to the prostatic urethra. So here's a really important slide. Let's go to prostate first. So the prostate makes about 20% of the fluid found in the ejaculate, and it's an acidic sample. The seminal vesicles make about 70% of the fluid in the ejaculate, and it's alkaline. So see, the seminal vesicle fluid overwhelms the prostatic fluid so that in the end, the ejaculate is alkaline and of a good volume. If you think about the vas, that contributes about 10%. And just sort of think about it as a neutral pH so you don't confuse things. So here's a sample. It's an azoospermic semen sample, but the volume is 0.6 cc's and the pH is 6.5. So what do we know about that just by paying attention to volume and pH? We know there's no contribution from the seminal vesicles, right? So either, as we'll see, they don't exist or they are blocked. It's a very simple and very straightforward differential diagnosis. So it's either going to be congenital bilateral absence of the vas, where the seminal vesicles are either absent, they're atrophic, they're dysplastic, to some whatever word you want to use, but they don't contribute to the ejaculate. Or it's bilateral, has to be bilateral, right? Bilateral ejaculatory duct obstruction, where the ejaculatory ducts are blocked so that not only the seminal vesicle fluid doesn't come into the semen, but also the vasal fluid. That's why they're azoospermic. So how do you make that diagnosis? You make it on physical exam. Please make it on physical exam. This is one of the most fun things in medicine, is to use your brain, then use your fingers, make a diagnosis. That's just so enjoyable. So What you don't need is you don't need a testis biopsy. You don't need scrotal exploration. And please, 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 is my own little thing here. You don't need a scrotal ultrasound. What you need is your fingers on the patient. You need to feel the vas or not feel the vas, right? But when, as urologists, we're so used to feeling the vas because we do vasectomies. So when the vas isn't there and you don't think it is and you're really searching for it, you're struggling, you're looking off and you're trying to feel it, it is probably not there, especially in the right circumstance. So palpation will lead the way for you. Now, let's get in just 4 slides on the embryology. These are actually pictures that will be published in an AUA update coming out soon. So not for general dispersal, but we can use them here. So the mesonephric duct, the individual early mesonephric duct is going to split into 2 different portions. The ureteral-renal portion, and then the reproductive ductal portion. And that happens around week 7 of gestation. Before that, it's one common mesonephric duct. So around week 7 of gestation, we can see that split starting to happen. So now you have the ureteral-renal portion and the male reproductive portion separated into 2 distinct tracts. The male reproductive portion is sensitive to and requires testosterone for differentiation, but the ureteral-renal does not. Finally, if we get to more of a mature system, we have ureteral-renal, and then this is the distal part of that reproductive ductal, off of which comes the seminal vesicle. Then you've got sort of the pelvic vas, and then the inguinal vas, and then the scrotal vas, and the distal 2/3 of the epididymis, not the entirety of the epididymis. And this is oftentimes a confusing subject, and you'll see why. It's because of the terminology that's chosen. So the efferent ducts, of which there are 8 to 12 or so that come out of the testis, that form the head of the epididymis, the caput of the epididymis, those efferent ducts derive from a different embryological precursor than does the remainder of the epididymis, the distal 2/3 of the epididymis. Here's where the confusion comes in terminology. The efferent ducts are mesonephric tubules. So I've italicized that. They are mesonephric tubules. They're what merge with the mesonephric duct here at the junction of the caput and the corpus. So the corpus and the cauda, the distal 2/3 of the epididymis, come from the mesonephric duct. That's what is affected in syndromes of congenital absence of vas, but not the mesonephric tubules. That's that confusion in terms of the terminology. You'll see why that comes into play in just a few minutes. So let's talk about congenital absence of the vas. Again, low volume acidic semen analysis. So if you've seen a semen analysis before you've examined the patient, you're already thinking about this. This is already rooting around in your brain, and there's no palpable vasa. See, so it's a very easy diagnosis to make. You can make it in 30 seconds just on physical examination. But there's always an epididymal remnant, right? That caput is always present because it comes from a different embryological precursor and is not affected in the same way that the mesonephric duct is affected. Testis size, consistency are normal because spermatogenesis is normal. This is not a problem with sperm production. There are 5 genetic etiologies to consider. We're going to go through each one of these a little bit. The first and the most common is mutations in the cystic fibrosis gene, which is located on chromosome number 7. So the CF gene encodes for the cystic fibrosis transmembrane conductance regulator, or CFTR, which is responsible to maintain proper fluidity of secretions in the respiratory and the pancreatic systems, and obviously the male reproductive ductal system comprised of the mesonephric duct also. Now, if that gene and the protein that comes from that gene is dysfunctional, then the secretions are thick and tenacious. That's what leads to the respiratory and pancreatic problems that we see and we recognize in patients with clinical CF. But I said that CF mutations were the basis of congenital absence of the vas and that they're the basis of clinical CF. So what's the difference? Why is there a difference? It's because of the nature of the mutations that you inherit from your mom and your dad. So if the nature of those mutations in combination is mild, then maybe you just have CBAVD. Your respiratory system, your pancreatic system is fine, but you're missing the VAS. Or the combination of mutations in terms of their effect on CFTR is more severe. Then you have pulmonary or respiratory, pancreatic, and absence of VAS. All males with CF, clinical CF, have absence of the VAS. So it's really just a spectrum determined by the mutations that you inherit. So if you inherit 2 severe mutations, one bad one from your mom, one bad from your dad, you will most likely develop clinical CF. If you have a combination, maybe a severe one, maybe a mild one, maybe you're someplace on the spectrum all the way from a little bit of CF to just CBAVD. If you inherit 2 mild mutations as they're classified, then you're probably not going to have clinical CF, but you might certainly have congenital absence of VAS. So the VAS and its absence is the most sensitive indicator of mutations in both CF genes that you've inherited from mom and from dad. When you do a CFTR mutation analysis, cystic fibrosis mutation analysis, you can look at a panel of mutations, you can look at an expanded panel of mutations, or you can do full gene sequencing, which is what I tend to do with the nature of the patients that I have. I point out this slide only because delta F and the 5T allele, as we'll see in a second, are the most common combination of mutations. 5T is a mildish mutation, whereas delta F is one of the more common severe mutations, the most common actually worldwide. In a study done in 2012, and this changes based on your ethnic population, based on how much you test and how much you look for, at least 46% of patients had 2 mutations identified, and 28% of patients had another mutation identified. So it's always been about 80% of all of our CBAVD patients, at least here in New England, where I have a Northern European background to most of the people here. About 80% will have a CFTR mutation-based congenital absence of VAS. Yeah, but not 100%. It's always been interesting about those other 20%. What is their genetic basis? We're going to find out in a second. Now, there was a move a while ago that said, well, why don't you just test the female? Because if she's negative, then as a couple, they're not going to have children with full-blown CF. But the problem with that is that the male that you're seeing has siblings, right? They're probably going to be in their reproductive age as well. So if he has inherited 2 mutations from mom and dad, then his siblings are likely to inherit maybe 0, but 1 or 2. So they need to know that. So family screening in any genetic disease is always important. A woman with breast cancer who has BRCA1 testing, it's not really for her, but it is to identify the risk that her offspring may have or her siblings may have. But it's also important to define for his medical history. So there's a lot of patients who come in, they do not have clinical CF as a diagnosis, but they've had this lifelong chronic sinusitis, a few episodes of bronchitis, maybe a couple of pneumonias in there. And when you define that they have mutations in their CF genes, then the treatment that they get for their sinus or respiratory illness is very different from what they got when the thought was it was just recurrent asthma or recurrent pollen-associated disease. So for the male siblings, but also for his medical history, important to go ahead with this testing. And then of course, it's really important to go ahead with the testing on the female partner, because what if she's a carrier for delta F508, again, the most common mutation, and our patient's delta F5T, they could have a child, if we just go ahead with our aspiration of sperm and in vitro, with clinical CF. You want to avoid that. So testing her is important because you want to eliminate the chances, or at least educate the couple that they have a chance of having a child with clinical CF, and allow them to make the decision about eliminating those embryos from transfer through pre-implantation genetic means. So that's the most common. But in just sticking with sort of the same flavor of genetic basis, there's a second one which now has been identified, and more papers are coming out. There's a beautiful paper coming out in Journal of Assisted Reproduction and Genetics in a couple months on ADGRG2. Now, ADGRG2 is located on the X chromosome, not chromosome 7, that's where CFTR was, but on the X chromosome. It's also a member of this adhesion class of G protein coupled receptors that is involved in fluid reabsorption in the efferent ducts. And that's pretty much how CFTR works as well. So it's interesting. It may be found, and I think depending upon your ethnic background, it'll be found in about 10 to 20% of patients who are CFTR negative and have a normal renal ultrasound. We're going to get to the renal ultrasound part of it in a second. So as you'll see in the last slide that I have, we'll go through a little flow diagram, and you'll see that renal ultrasound precedes the testing for this. But it is one of the mutations and genes that we're finding that I think is going to become more and more commonly assayed for. It's interesting too, we're going to see a slide in a second, as to what that location on the X chromosome means. And here that is. So let's say we have a patient and his X chromosome has ADGRG2 with a truncating mutation on it. Well, we can find sperm, we can help them to achieve a pregnancy, and his children, their children are going to be fine, but each one of the daughters is going to carry that X chromosome from the dad that has that mutated gene, and therefore 50% of her offspring. So our patient's grandsons may be afflicted with the same disease as well. So see, that knowledge is important for patients, because way back here, they may decide through pre-implantation genetic diagnosis to just transfer embryos that will become normal, healthy males. To actually limit the vertical transmission of this mutation in their own personal family tree. That's just education that we should provide to patients. Now, there's another one that's very recent, SLC9A3. We're not going to go through this at all. It's just a very few patients, but it's the same kind of gene and protein that it interacts with and encodes an ion channel that interacts with CFTR. So see, a lot of the probably ones that we're going to figure out in the future, in the next several months or several years, are going to interact with CFTR in some way. So CFTR is still this linchpin to all of this. Now, the second most common etiology, and this is what gets into the embryology of it all, is related to renal agenesis. This is a disorder that is not related to CFTR mutations. It's not related to mutations in ADGRG2. 5 to 10% of all our patients with CVABD have unilateral renal agenesis. And so it's probably a completely separate etiology that involves mesonephric duct differentiation. Remember, we talked about this embryologically. So that would be something that affects the mesonephric duct prior to week 7, prior to that split into reproductive ductal and ureterorenal portions. So something that affects that common mesonephric duct. And the transmission, as we showed in a paper a long time ago, could actually be bilateral renal agenesis. So here would that situation be? Obviously, a patient born with bilateral renal agenesis cannot present to someone like me at age 25 or 30 because he had bilateral renal agenesis, unfortunately. But if you had just the same disease but slightly less severe phenotypic expression, and you had 1 normal kidney but 2 absent vasa, then you can present to me when you're 25 or 30. You have absence of the vas and unilateral renal agenesis. And so this is the second most common of the etiologies. So here's my last slide for you. It's just a nice algorithm. We're just going to go down this branch here, as we were talking about bilateral absent vasa. So you do the physical exam, you have absent vasa, do a CFTR analysis. If it's CRTR negative, so that CF mutation analysis is fine, didn't show you any mutations, then you need renal ultrasonography. Once you get renal ultrasonography, then if that's, let's go this branch, unilateral renal agenesis, well, you know at that moment, that's your diagnosis. It's that second most common etiology. But what if that's normal? See, then you're looking for the third most common genetic diagnosis, which would be mutations in ADGRG2. Obviously, if you're CFTR positive for a mutation, then obviously we talk about partner analysis, and negative and positive. If it's positive, that's where we want to go ahead with consideration of PGT. So that's pretty much my time. I'm just checking my little clock here. 18 minutes. And so my last slide is just this. So in conclusion then, for all of you, the semen volume and pH are important. So always pay attention to that when you have a semen analysis and it's azospermic. The physical exam, I'm telling you, don't forget about it. It's fun and it can be diagnostic in this consideration. Embryology is also fun, and it allows, as I mentioned before, an understanding of these disease processes and what you find actually clinically. CBAVD has many genetic etiologies, which we just went through. And probably the most important message is that genetics and male reproductive medicine and surgery are intertwined. So if you love genetics, this might be a field for you. If you love this field, male reproductive medicine and surgery, then you need to understand, you need to like genetics because it is such an important linkage. So let me stop there. And Mary, I'm not sure if you want questions now or questions at the end.
Let's do questions at the end, just to sort of stay on close to on time. But I thank you so much for that talk. I think hearing you speak, it definitely reminds me of sort of some of the reasons why I went into reproductive medicine. And so I think it's both educational and also your sort of passion shines through. Our next speaker is going to be my fellowship mentor.
Samplaski, could you switch on your video?
I actually can't. It says that the moderator has.
Annie, could you switch on Dr. Samplaski's video, please?
Thank you. Our next speaker is Dr. Keith Jarvi from the University of Toronto. He was my fellowship director, and I'd say on a personal note, his daughter is a Olympic level swimmer, and I have fond memories of him reviewing manuscripts that we were writing together from poolside, and he got me the best lobster dinner I've ever had at the end of my fellowship. He is an absolute superstar. He's doing some exciting things. He's very much involved in the translational aspect of reproductive medicine. So I'm honored to have him speak with us today. Dr. Jarvi?
Thank you very much, Mary. I'm going to try to get my slides up here and make sure this actually works. Okay, great. Can everyone see that now?
I cannot. I can.
You can? Good. Okay.
Yes.
Great. Let me just, listen, it's an honor to be invited. Thank you very much. I'm just going to make sure I'm going up here. Mary was a superstar when she was there, very productive, and we had a lot of great times together. What I'm going to talk about is, it's not really a continuation, but I want to talk for maybe about 15 minutes in total on going beyond the semen analysis. And some of this is innovation and the kinds of things that that you may think about if your resident's going through. You want to go into an area, the area of male infertility is an area which involves a lot of innovation. Actually, urology in general involves a lot of innovation. So one of the areas that's big unknown, if you get an area that's unknown, start thinking about what you can do to try to improve it. And one of the big unknowns for us is the azoospermic patient. And normally when you do a semen analysis, you're looking at, as Bob Oates just said, you're looking for the semen volume, but you also look for the sperm counts, how many sperm you have, how the sperm move, and the morphology of the sperm. But for patients who are azoospermic or have no sperm, this classical one that even the oncologists in the room will remember from their medical school and first couple of years of residency training, it'll inevitably be on your exam, so you have to know this. If you have a patient who's azoospermic, they don't have CBAVD, is actually not a common cause, but you have to differentiate them between the non-obstructive and the obstructive ones. This is the obstructive ones with good sperm production and the non-obstructive group over here. So the problem we have right now is that if the FSH is high, it automatically defines these guys as being non-obstructive. If the FSH is normal, which is actually the majority of the men, we actually don't know if these guys are going to be azoospermic due to non-obstruction, testicular failure, or obstruction. Basically, the tubes are either missing or obstructed. And that's a big problem for us because in order to differentiate that, right now, we need a testicular biopsy, histology. So this is one big thing. So can we actually avoid doing a testicular biopsy? And I'm going to go through some of the things that we've been looking at for the past couple of years. And then going down a little bit longer, further down, if you're in this side where you have a diagnosis of spermatogenic failure, we have a technique to try to retrieve sperm in these patients. And we don't actually know from many patients if they're going to have sperm, we have to do surgery. So can we avoid surgery? So thinking innovatively now, as the residents in the future, how do we diagnose NOA versus OA, non-obstructive versus obstructive azoospermia in these patients? So again, if you have obstructive azoospermia, something is blocked in this passage on the way out. If you're Bob Oates' patients, you're missing a tubes. The majority of them, though, will have some obstruction either here, or if it's non-obstructive, it's going to be a factory issue, production issue here. The problem right now is there's actually nothing to differentiate between those two short of a biopsy for most patients. So we've looked at a number of blood markers, genetic markers, none were actually very good. So this is actually a huge area because patients don't like the biopsy. And this is where it got interesting. And again, I'm going to try to talk about a bit about innovation here. So we decided to look at the semen to see if there are markers in the semen that might indicate whether or not it was spermatogenic failure or obstruction. And through a series of proteomics works where we actually compared the different proteins in the different categories of infertility, we came up with some markers. And the interesting thing is, if you're interested for a marker for obstruction, you want a marker that comes from the epididymis. If you're interested in a marker for testicular failure, you're trying to find something that highlights the sperm production. So after a few years of work, we're able to identify a epididymal specific marker called ECM1, just produced in the epididymis, and a couple of other markers that are just produced in germ cells. And you can see how valuable these can be. And this all came about because we were just wondering how could we differentiate obstructive versus non-obstructive. And so you guys can think about how to do this. So the first thing got us very excited. We took these particular markers, which were at that point available to us. We then tested it, and we could differentiate obstructive versus non-obstructive with almost 100% specificity, and sensitivity is very high too. Very exciting for us to find this out. We filed for the applications. Everything was fine. This is another part of urology. It's very interesting. If you have an interesting discovery, how do you actually get that out so that someone in California could use it and someone in Toledo can use it, etc.? You have to actually go through the commercial route. And this is a whole new thing for learning for urologists, but a very exciting area. So if you guys get into it, don't shy away from trying to develop new products that are really valuable for the world. So we actually went through the whole thing where we went through the companies. We looked at the impact of this, looked at how much it would affect the costs for insurance companies if this is better. And guess what? The end user for this particular product was not going to be urologists. According to the companies, it was going to be the gynecologists who were at the IVF clinics. So this to us was kind of a very disappointing outcome, but not one that we were completely not unsurprised about. Again, you start thinking about doing the innovation, but then at the end of it, how do you actually market this and get it out so that everyone can use it? Very interesting. Next, so that's the one thing that we came up with. The next one is, can we use this particular kind of idea to help predict retrieval rates for men with spermatogenic failure? So just quickly, if you have spermatogenic failure, it doesn't mean that there's uniform failure to produce sperm within a testicle. You may have small islands where you have a little bit of sperm production. And in order to retrieve these little bits of sperm, we have to do a micro-TESE, or there's other techniques that are available, but essentially it's a fairly long procedure which will identify these little isolated pockets of sperm, and usually we can isolate them and identify them by physical characteristics under the microscope. And here you can see, this is sort of like a prototypical one that we all love to see, where you can see that these tubules look much larger than the surrounding tubules, and we would highlight and take these out. If you can identify these areas, the chance of finding sperm here is actually very good. So instead of taking big pieces of the testicular tissue, you've highlighted one little area, you've taken it out. And this is a very standard technique now. Mary uses this, I'm sure, quite extensively in California. Problem was, the patients coming to us, only about half the time could we find sperm using that technique. So the next issue was, can we find a marker which would help to identify those patients who are more likely to have sperm production than those who are unlikely to have sperm production? It turns out that a marker for the same kind of thing that we help differentiate obstruction from non-obstruction is also useful in differentiating this. So we then went on to find these markers, and you can see the histology here from the patients with no sperm production. It's pretty clear there's nothing showing up. We looked at the seminal plasma, and yes, these markers help to differentiate production versus non-production. But the problem is, in order to make this widely usable, you have to have something which is high throughput. In order to do this high throughput, you had to turn it from a mass spectrometry procedure into an ELISA test, which is a fairly inexpensive test. The problem we had is there are no antibodies available for these particular proteins. So we actually had to make our own proteins, make our own antibodies, and generate our own monoclonal and ELISA kits, which took a couple of years to do, very long procedure. But once you get this, these are extremely cheap, reproducible, and high throughput. So we then, because these are cheap and high throughput, we then started to look at what Text 101 does. And it turns out, and this was something that we came across a few years ago, that if you look at reports, Text 101 in knockout models, turns out that the mice in the knockout models are infertile. Very interesting, exciting. So we looked at 800 of our patients down here who had provided semen analysis, and these were patients who had had no sperm, normal sperm, low sperm counts. And in the infertile men with, reasonably good sperm counts, we had about 7% of them that had very low marker levels, Text 101 markers. So this looked like a very good way of differentiating the patients who had idiopathic infertility from normals. If you had this, you might have infertility. The problem was mice are not humans, and this turned out to be not real news. So we then studied a very large population from Iceland, and based on the genetics, it turns out that the genetics that knock this particular gene down in humans is very common. The genetic alterations that knock this particular gene down is very common. And there's a very good population in Iceland where this gene is knocked down. Unfortunately, all these men were normally fertile. So we went through all of this work, went through the discovery just to find out that this was actually not a good marker for infertility among the men who had normal sperm counts. Okay, important. However, it is actually quite a good marker to differentiate those who have good sperm production or some sperm production from those with no sperm production in men with spermatogenic failure. And again, I'll just go back through this. So looking at the patients, if you're looking at patients who are azospermic, you can have the guys over here where it's normal. You have patients where you might have a little bit of sperm being produced here and there, and those are patients where the microtesty is likely to work. And you could have maturation arrest or Sertoli cell only, where that's where the sperm retrieval would be negative. And again, this is just to reiterate what we're going through. So since our markers were germ cell specific, we predicted that if Text 101 was high, it would probably be normal. If it's low, it could be either maturation arrest or something like a late maturation arrest or hypospermatogenesis. And if it was in this pattern here where there's no sperm production, then we would have very, very low marker levels. So this seems like an easy study to do, but unfortunately it's a study that takes years to recruit patients. And here for the first time is the report on this. So if you take men who have low marker Text 101 and it's undetectable, they don't have any sperm ever in the ejaculation. So number of men with spermatogenic failure, if you repeat the sperm test multiple times, some of them will occasionally have sperm in the ejaculation. If you repeat these tests multiple times, and this particular marker was 0, they never had sperm in ejaculation. This takes a long time to recruit these patients. This is probably the most important thing that came out of this, is that if the marker was absent, and you then went ahead and tried to retrieve sperm from these patients with the surgery, this group right here never was sperm identified out of 20 patients. And this is between Toronto and Cornell. So this is actually a very good marker, and half the time it was detected in those where the marker was positive. So it's actually a very good marker, which we've just come through, which differentiates those where the chance of finding sperm is very low from those where the chance of finding sperm is actually pretty good. So if your test is negative, it's a very good predictive marker for the chance of finding no sperm. So this is what we eventually came up with, and hopefully this will come out shortly, but this helps to differentiate obstructed groups, where the ECM1, that's the epidermal marker. If that's low, it indicates obstruction. This is a very good marker for it. If it's spermatogenic failure, but you manage to find sperm, if this particular marker is normal, we actually have a very good, reasonably good chance of finding sperm. But if the marker is very low, we actually have a very good chance that they won't find sperm. So this is actually the strongest marker we have for a failure to find sperm. Now, that's exciting and actually very functionally usable for those of us doing infertility. But think about this. As we get more therapies for patients with non-obstructive azoospermia, you might be able to look at whether or not they work by looking at this marker in the semen. The second thing is men's sperm counts do tend to go up and down with time for reasons that we don't always understand. So, and this is just a man who provides a sample over the course of 2 years. You can see how it goes up and down. So it's likely to go up and down in the guys who also are not producing a lot of sperm. So we could potentially use this as a marker for when to do the surgery in the patients. Okay, so this is the final thought for the residents. I know there's more than residents on here, but this is similar to Bob's thoughts minutes ago. Innovation is fun. You came up, there was a problem that we had. You can think about innovative ideas. We're really in a good, urology is a good area for innovation and opportunities. Innovations from, new ways of putting catheters in to new ways of heating up the prostate. It's an area which is filled with opportunities for innovation. And it's the kind of thing that can get you up in the morning and get you to school and get you to work. That was my last slide. I'm going to leave it for Mary. Thank you very much.
All right, well, thank you, Dr. Jarvi. That was a wonderful talk. I'm personally, I've been following your work with Text 101. I will be very curious to see when this is ready for primetime usage. And I think certainly anything that we can do to help predict which guys are going to have a successful microtesty is super useful. So our final speaker for this morning is Jim Hotaling. Am I frozen?
You're good. You're good.
Okay. My screen's frozen, but that's okay. Our final speaker is Dr. Hotaling from the University of Utah. Dr. Hotaling is an avid mountain biker. He moved to Utah because he loved the great outdoors, and I love hearing the stories of what what he's doing out there. When I see him at the meetings, it's usually something like some kind of active activity in the morning and then working on papers in the afternoon. He has a wide range of interests, and he was recently published in JAMA but on an equally exciting, although certainly a different audience front. His work looking at the impact of COVID on male fertility and sperm was actually recently published, but then also featured on Saturday Night Live's Weekend Update. So Dr. Hotaling, it is an honor to have you here. He's going to be speaking about the Sperm Olympics, which is a new event for me. But I know he's going to be speaking about microfluidics, as well as this concept of growing sperm, which is something that comes up in everyday practice. So thank you for being with us, Dr. Hotaling, and take it away.
Okay, can you see the screen?
Yes.
Okay, perfect. Let's get this. Sorry. Okay, so I'm gonna kind of try to talk quickly about a bunch of different interesting research things, and Keith's talk was kind of a perfect lead-in to the last two components of this this talk. So these are my disclosures. One of the companies, Nanonc, that I founded, does do the microfluidic sperm sorting. The other companies don't have anything to do with what I'm presenting. In terms of learning objectives, I'm going to try to describe how male infertility impacts somatic health, and then also talk about the role of microfluidics, and then finally talk a little bit about spermatogonial stem cell culture. So we've done a lot of work at Utah with a cohort we call SHARE. We completely made that up. Subfertility health, assisted reproduction, and the environment. Utah is a really unique state for a number of reasons. It's a really big area, geographic area, but a relatively small population, 3 million people. It's also the only state where a majority belong to one religion, the Latter-day Saints or Mormons. It's also, interestingly, somewhat of a founder population. The Mormons came there in 1860. And for religious regions, keep extensive pedigrees. So we have a database with pedigrees on 50% of the state. It's the database where the BRCA gene was found, the APC gene. It's really powerful. So the UPDB has been called, this SHARE database and what it consists of, the Utah Population Database, has kind of been called the Hubble telescope for human health. And we basically tried to use that to look at sperm. So this is actually a picture of the Hubble telescope. This database is massive. It's got 20 million records, birth certificates, death certificates, complete medical records on 85% of the state, driver's license data. It's kind of amazing that we have this. I don't think in states, a state such as New York or California, this would probably fly. And you have no choice whether you're in the database. Everyone's in the database as soon as they move to Utah. But it allows a lot of really cool research, especially because we can look at life course history. So there's a lot of data linking male infertility and somatic health. And our thought was, how does male infertility impact familial health? The idea being that whatever drives male infertility in an individual may be a genetic component that actually tracks in families. So we wanted to look at this and see, and as I mentioned, we've typically focused on the proband. And the big question we ask is, what if male infertility and sperm count was a biomarker of familial health? This is a really complicated thing to study for a number of reasons, but we've sort of made slow and steady progress over the years. So individually, male factor infertility is linked to diabetes, cardiac disease, alcohol and drug use, mortality, a number of different cancers, maybe psychiatric disease. Mike Eisenberg's done a lot of this work. I've done a little bit. When we look at familial health, we found through using this big cohort that family members of infertile men are more likely to have testis cancer, thyroid cancer. Their siblings are more likely to get ALL. And really interestingly, their siblings are also more likely to die from major congenital anomalies, which suggests that whatever is driving male infertility, there's at least some genetic component that's tracking in families. So these are just the references to our papers. So sort of in summary, when you look at this, you can see here's what we found for first degree relatives, some differences with azoospermia and oligospermia. And what we've kind of surmised from some of this is that the biology of azoospermia is a little bit different from the biology of oligozoospermia, which is also exactly what Keith was talking about. I don't have time to get into it here, but we see a stronger signal in first degree relatives, and then we still see a signal in second degree relatives, but not as strong. The mechanism of this, we think it's probably genetic. It's also possible that a family lived next to a toxic waste dump for generations, less likely, but possible. We do have more Superfund sites, which are some of the most toxic sites in the United States that have been cleaned up in Utah than anywhere else. Epigenetics are another possible cause. So we also started to use this looking at pedigree data. And, you know, on the left, it's an example of what we would call a fat pedigree. And pedigrees like this historically in the UPDB, amazingly, are not that atypical. I mean, just a lot of massive families. So we looked at pedigrees on all these patients, and you sort of have an example of what's a fat pedigree or a wide pedigree, and then a skinny pedigree or a narrow pedigree where, you know, families tend to have fewer children. So the objective was to understand how subfertility relates to intergenerational family size and identify a cohort of families with small intergenerational family size. And the hypothesis, which when we've presented this at meetings has been met variably, is that men with low total motile count have smaller intergenerational family size. And we used a cohort of 26,000 semen analyses. We can go back historically and look at their relatives. We use 1935 because that was when birth control was readily available. And these are essentially all Mormon families that certainly in that period almost uniformly desired large families. So we built this final cohort. We ended up with 2,100 patients. And we looked at total motile count as a continuous variable. What we found is for every additional child in a man's historical pedigree back to 9 generations, you see an increase in total motile count of 1.88 million, which may not seem that significant. It does meet statistical significance, but another way to put that is that, you know, men in the top quartile of intergenerational family size had a total motile count that was almost 50 million higher than men in the bottom quartile over multiple generations, which brings you to the next question, you know, why is this? So Aaron Quinlan is a computational biologist that we've worked with, and they have these families that they have multiple generations and they have whole genome sequencing on them, so they can look at de novo mutation rates. So 33 large Utah multi-generation families with an average of 8 kids per generation, which would be hard to find almost anywhere else besides Utah. They looked at the de novo mutation rate, and they found that in these families, it varies from 0.2 to 3.24 across the different families. Most de novo mutation is driven by the male, about 75% of it. Interestingly, they found that families with a higher de novo mutation rate have much higher rates of cancer and die on average 8 years earlier. So essentially what you're looking at here is there are families that have a higher de novo mutation rate, which begs the question, which we're looking at now, is it possible that these skinny pedigrees have a higher de novo mutation rate, and that actually is the linkage between male infertility and poor familial and somatic health? So more work is forthcoming on that, but it's an interesting, it's certainly an interesting area of investigation. So I'm going to switch gears a little bit and talk about essentially what Mary referenced is the Sperm Olympics. So this is microfluidic sperm sorting. And as you know, Keith and Bob mentioned, obviously for IVF, you're looking at, you know, one sperm, sometimes 20 sperm. And it's really important to pick the optimal sperm. Right now, we kind of look at the sperm, figure out one that moves well and looks good, beat it up a little bit with a pipette and inject it into an egg. You know, so the goal of this company is not to replicate this. You know, we're trying to do good science. We have no commercial market, no commercial product on the market. We're working towards it, but we're not there yet. So spermatogenesis is really high throughput. Most men are making, you know, 1,000 sperm a second, and it's a complicated process. And obviously there's a huge number of sperm, you know, that could potentially fertilize an egg. So you have all these spermatogonial stem cells that make sperm, And what we're trying to do is find the spermatogonial stem cell that's making the best sperm. And one way to do that is to look at how it swims. The ultimate goal of this is to do non-invasive imaging. We've done some of that through Raman spectroscopy and flowing individual sperm through a chamber and figure out a way to identify the optimal sperm for IVF or insemination without killing it. We're long ways from that, but we're working on it. So this is the device that we use. These are spiral channels, and essentially the sperm is put in one port and then it flows out through the other, and it separates it into the sperm that look more normal and from all the debris. So, the dimensions of the device, I list here. This is essentially how it works. And we have this developed both for IUI sperm prep and for processing of microtessi. The sperm flows through this channel and gets pushed through by a syringe pump. And these devices are very inexpensive, like a few dollars to make. And then the red blood cells and the debris go one way, and then the sperm and the excess media go another way. Then we can rerun it iteratively, so you can get this significant enrichment. The sperm search we found when we looked at this is accelerated by about 10-fold. And what we thought was this could improve the sperm search success rate. And we looked at sperm found through microfluidics in samples from men with NOA undergoing a microtessi. And we found that these samples were cleaner, had a higher concentration of sperm found per unit time, 2 to 20 times higher. It took about 90% less time to process. You'll also see in looking at their data, or in our data, which, you don't need to bore yourself with this giant chart, but, we do have at least one patient where we found sperm with the device where it wasn't found otherwise. This was recently published in Urology. And, when you look at this, you see that the device does find, sperm significantly quicker, more sperm. And actually it also puts, compared to a centrifuge, it puts a lot less force on the sperm, 500 Gs versus 6.2. So that's kind of microfluidics and where it goes. I'm gonna close out by talking about spermatogonial stem cell culture, and Keith kind of led into this talk beautifully, talking about some of the problems we have with identifying who's going to have sperm on a microtessi for men with non-obstructive azoospermia. So one example for this is trying to understand obesity and sperm, and try to convince you guys that culturing spermatogonial stem cells might be able to blunt some of the detrimental effects to offspring that happen in obese men. So this was a paper we published in Cell Stem Cell a couple years ago. And what we did is it took 3 years, took 8 fresh whole human testicles, which were basically done patients the end of the road for severe testicular pain. If anyone wants to volunteer to participate in our research, you're welcome to contact us. But in reality, we found a pipeline of cadaveric organ donor tissue, and we're now getting 40 to 50 specimens a year from neonates all the way to age 75. And this is an incredible resource for research. And I really encourage other people to think about talking to the transplant surgeons and the donor program about this. So when we look at this, we can do bulk and single cell RNA sequencing and really profile each individual cell. And essentially, when you sort all this out, the spermatogonial stem cells break down into self-renewing and differentiating, and there's markers for that. And the self-renewing are SSEA4 positive. The differentiating are KIT positive. And the thought was, if you could culture this and understand these cells better, could you actually manipulate the media that you're culturing them in and make sperm that weren't impacted by the fact that the man was obese? And we have not done that at all, but that's the ultimate goal. So the other really interesting thing is when you look at this data, these are different states of spermatogonial stem cells. So state 1 is, self-renewing. And then state 4 are, the cells that are actually making sperm. And we looked at what differentiates these cells and how the gene expression changes. And what's really interesting is metabolic changes are a big part, which you see in cluster C, of kind of driving that, transition, which again makes you think that may be part of the reason that, obese men have, there's a transgenerational impact of obesity. In other words, that obese men are significantly more likely to have obese children and have changes in glucoregulatory genes in those children for the rest of their life. So, this begs the question, if metabolic transitions govern spermatogonial stem cells, does the altered metabolome get recorded somehow? Would there be evolutionary advantages to this? Potentially. Could SSCs serve as a tape recorder of nutritional exposure that's passed on to offspring? There's a lot of evidence for this in animal models and certainly some evidence in human models. What's the mechanism? MicroRNAs, methylation, protamination, kind of a number of different things. So the next thing we did is we built a human testis transcriptional cell atlas. And this was published in Cell Research in 2018. And essentially here we did single cell sequencing of all the different stages of spermatogonial stem cells and sperm development, and then clustered it by the gene expression. And what you can see here is if you follow that number from 1 to 8, you're actually watching the transition from spermatogonial stem cells to sperm. And what we found is that what's happening in humans is fundamentally very different than in the rodent, which is probably why we can culture spermatogonial stem cells in mice and not in humans. So, this is essentially, how we did this. We took, these healthy, donors age 17, 24, and 25, and we did use the 10x genomics platform to perform, single cell RNA sequencing, and we can look at the expression of each individual cell. So essentially what happens is when we run these cells, when we run the tissue through, we'll get 6,500 cells, and we can look at the complete RNA expression in each cell on a single cell level, which gets very, very powerful. We can also look at Leydig cells, Sertoli cells, endothelial cells. So this is kind of the, approach, we've taken. These are foundational data sets enabled by cadaveric tissue pipeline. And again, we look at the gene expression across the whole range, and you really have to do single cell to tease out this information. And the goal of this was to try to use this to learn to culture things. And when you recluster these spermatogonial stem cells, you see that, before, if you notice, we had state 1 through state 4, and we did this again, there's actually a state 0. And the state 0 is sort of the cells that make, the cells that renew the stem cells, if you will. And we feel that that is the critical state to understand in culture to actually achieve the goal of in vitro spermatogenesis. We see that there's also fundamentally some back and forth between state 0 and state 1 in terms of how things are expressed. And the attack-seek is kind of what genes are turned on and turned off in terms of chromatin. And you see there's this dynamic interplay, and things are moving bidirectionally to maintain cell populations. And if you're not maintaining that in vitro, it may be part of the reason that no one can culture these cells. So, finally, we took a look at this during puberty, and we look at a 1-year-old, a 7-year-old, 11, 13, 14, and 25 doing the same thing. And you can essentially see spermatogenesis turn on throughout puberty and see how these quiescent cells become activated. We're trying to use that as a roadmap to culture. You can also see how Sertoli and Leydig cells change, which we actually feel is a really important part of the story if you're going to try to culture these cells. So I have 2 more slides, and then I'll finish up. We also, for this paper, looked at transgender patients. We have a lot of patients we're doing vaginoplasties on, and we can look at testicular tissue and see what happens. And what we found, through working with this is that testosterone is one of the critical things you need to culture. And you can see at 3 weeks in the media where there is testosterone, we're trying to culture these cells, the culturing goes much better, and it looks much more like healthy tubules. So, sort of in summary, these cells are really high throughput. We have these, several different papers here looking at this, and what we're trying to do is get a roadmap for how to culture cells. So what does this mean for the field? I think it holds a lot of promise for identifying and potentially correcting spermatogenic defects. Also, manipulating and profiling cultured spermatogonial stem cells and sperm while it has ethical issues, it probably has less ethical issues than CRISPRing human embryos. And the race is kind of on to see who will get there first. So that's kind of the conclusion of my talk. Thanks for listening.
Thank you so much, Dr. Hotaling, for that wonderful discussion. I think the database that you guys have out in Utah is certainly a huge tool, which I know you take advantage of. But you guys are doing some very high level basic science stuff up there, and so congratulations for that, and thanks for sharing. I don't know if there's a few sort of questions on the chat. I don't know if the panelists have time to go through a quick case, or if we should wrap it up. Dr. Gill?
I think, Mary, maybe the panelists could look at the question answers and type in the answers, but I think you should go ahead and do one case.
Do you guys have time? Okay.
Sure.
All right. So what I don't, Gio, I may need some technical assistance with screen sharing. Oh, here.
Yeah, Mary. So
Desktop, right?
yeah.
Okay. All right, can you guys see? Is it screen sharing?
Yes.
Okay. This is a guy that I saw in clinic. He's a young guy, 18. Medical history significant for undescended testicles, but the right undescended testicle, which was pexed at 1 year of age. To Bob's points, what we do is exciting, and you can get a lot from physical exam. Testicular volume was normal with no masses. He did have a grade 3 varicocele. I started taking things a little out of order just for the interest of the case. He came with a bunch of records, but his vasa was palpable, but he did have a varicocele, but the testicular volume was preserved, and there didn't seem to be any atrophy or sort of diminishing consistency. So they came with records showing normal volume azoospermia, centrifuge sample confirmed with the second semen. Once I sort of found the varicocele, I asked him, do you have any pain related to this? And he said, yeah, a little bit. Like, it definitely aches, and I myself pretty routinely. And I said, well, you're a young guy, does that bother you? And he's like, yeah, I mean, it's not like the end of the world, but it definitely bothers me. So I guess for the panel, the next thing I checked was hormones. His total testosterone came back at 626. FSH was 4, LH 5.9, prolactin, and these were not drawn by myself. And then I guess for the panel, what would you do? What would you order next?
So I guess I'll start. I mean, someone had asked this question about varicocele, which is such a good question. So the first thing I would do is, one, it sounds like he needs his varicocele corrected anyway, just for his pain and the aching and all of that. But if he wants to pursue his fertility at this point, or pursue the investigation of his future fertility, I should say, then I would do a wide microdeletion assay, and I would do a karyotype. Because if they show findings, that'll be important for his future. And if they're negative, that's great too. But I certainly wouldn't do any kind of TESI at this point in time. I would wait and until he's ready to try to have a child. And at that point, that's when I would offer him micro-TESI and things like that. But I think that genetics at this point in time are important, just to give him some sense as to what the genetic etiology might be.
Dr. Jarvi or Hotaling, anything to add, or you concur?
So if you're convinced that the varicocele is causing the pain, I agree, fix the varicocele. You never know if the varicocele is the cause of the pain until after you fix it. It's one of these horrible diagnoses. It's made after the fact. If it doesn't work, it wasn't the varicocele. If it worked, it was the varicocele. But he has symptoms which are compatible with varicocele pain. I think it's reasonable to fix it. And whether or not you do the genetic testing now or later, I would have that discussion with the patient. I agree with Bob that it's reasonable to do it now. I don't think it's absolutely essential to do it now, depends on how sophisticated this kid is and how much concern he has. It doesn't actually make there's nothing actionable. You're not going to do anything with that genetic testing now anyway. He's not going to have CF. And apart from CF, even if he has a Y microdeletion, you're not going to do anything about it right now anyway. So medically, I agree, fix the varicocele and then wait.
Yeah, I would also agree. I don't always fix varicoceles in the setting of azoospermia, but I think it makes a lot of sense. I mean, it's a grade 3, you know, and he's interesting in that, you know, the FSH is not that high, you know, and if you just saw this and couldn't do an exam, you would think that, you know, maybe it's potentially, you know, could be obstructive, but you also have the varicocele there. So I would do exactly what these guys are saying. And I think the genetic testing is just sort of you have to have a conversation with him and possibly also his parents about, you know, when they want to do this. I find after that conversation, a lot of kids actually want to know just for the future.
What about the undescended testicle? Because this also sort of played into our discussions. I mean, I saw him with his parents, and obviously they want grandkids. And
yeah, and certainly, you know, we know that individuals with undescended testicles have lower rates of fertility. You know, I mean, I've also seen patients who've had bilateral orchidopexies who have had the vas deferens obstructed, you know, on both sides from that. He's obviously had, you know, like a unilateral side, but I think that definitely makes me think sort of, you know, maybe moves me a little bit more towards the camp of thinking this might be, you know, non-obstructive.
so we did the genetic testing, you know, and I think to your guys' point, these are very sort of tailored treatment decisions, right? I mean, this kid he came in, he had actually seen a different urologist, a general urologist out in the community, had actually been told that he couldn't have kids. And he was really sort of in his head about this. I think it's sort of understandable. I mean, that's a big thing to tell an 18-year-old that long-term you're not going to be able to have kids. All of them, both parents, the child, everybody, or the kid was, well, young adult, had been online with all kinds of sort of information, some of which was a little bit more sort of accurate. So we did the karyotype, and it was, I mean, I'm sure we've all had these discussions. It was definitely a bit of like, okay, sort of, here's what we should be doing. Here's the factors at play. And so we ended up doing the genetic testing. The karyotype was normal. The Y chromosome was normal. The karyotype showed this sort of unusual translocation. And for this, I ended up sending them to genetics. They had a little bit of a tough time, they were HMO finding somebody to sort of see them for this. But yeah, for all the reasons that we talked about, even with this information, we decided to fix the varicocele for the pain alone. His pain was very consistent with varicocele pain. But we did have the discussion of, you know, it's always hard to predict who's going to get better. I can't promise you that this is going to get better, but based on everything that we've talked about, it seems that there's a good chance that this will help your pain. Interestingly, both the parents and the patient, after discussion, because he was asleep, asked if we could perform testicular bilateral biopsies. And we made arrangements with the cryobank because he said, I never want to have this done down the road. I mean, we had the discussion about the varicocele, fixing the varicocele may result in resolution of sperm to the ejaculate. At this point, he just really wanted to know if he was making sperm. So interesting that we found his pain got better. So we did the right thing for the varicocele. On the right side, the undescended side, the lab did not find sperm, which is interesting because obviously we know that pathologies that affect one testicle can actually affect spermatogenesis on both sides. But on the left side, they did find sperm. I mean, there was, you know, and we've all had this experience, but there were, you know, tears in the recovery room of joy. And like, he was, you know, everybody's just so happy to know that initially he'd been told he couldn't have kids. And now, you know, hopefully he can have kids the natural way is what sort of the discussion that we had. But if nothing else, he has sperm on ice that he can use down the road. He was supposed to have his follow-up semen analysis, his 3-month semen, about 2 weeks ago. This has not happened, but you know, he's reasonably happy at home. He's completely healed up. So, you know, I think one of the hotter topics in infertility right now is the role of varicocele repair in guys with non-obstructive azoospermia. You know, I'll be curious personally to see if the varicocele repair helped his sperm production. So that's the end of this case. It's not super long. I figured we were going to be going along with the case with the presentations, and I really wanted to hear what the presenters had to say. You know, in the interest of time, Dr. Gill, should we sort of wrap it up?
Yeah, thank you very much, Dr. Samplaski. Terrific job. We really want to thank the panelists, Dr. Jarvi, Dr. Hotaling, Dr. Oates, stimulating work that you're doing, and your overall points about urology being a specialty where innovation is absolutely what drives us. And it's a lot of fun. I completely agree. Drives us and gets us out of bed with a jump every morning. Thank you so much for educating all of us, for coming on board today. You had a really excellent conversation and an excellent viewership today. So compliments on that. From USC Urology's perspective, if folks want to go and see where we have this on the YouTube thing, our team has put together the Urology 60 Minutes YouTube channel. We have over 3,500, 4,000 views already about the recordings of the prior Urology 60 Minutes. It's growing significantly. Also want to tell you that for next Thursday, we are going to be talking about muscle invasive bladder cancer. We have an all-star cast again, Dr. Colin Denny from MD Anderson, Dr. Rosenberg from Memorial Sloan Kettering, and Dr. F. Steihow from Mass General Hospital. And it's going to be hosted by our USC Urology's Dr. Human Jaradar. Thank you very much. Thank you, Giovanni, for the excellent work you're doing to put this together for the team. And be safe out there. All the best. And thank you again to our very distinguished panel this morning. It was.
Thank you, panelists.
It's a lot of fun. Thank you.
Thank you.
Bye-bye. Bye, Mary.
Bye-bye.